Very good morning and welcome to all. Today we are discussing imaging of chest wall and pleura and diaphragm. I'm Dr. Nithish here. I'm Professor Radiology. We'll have some images of radiograph, CT scan, ultrasound images, MR images. So we'll go through them. We'll have a discussion about that. So this is a chest radiograph, posterior anterior view, and what we are seeing here is this is uniform lung field on the right side. On the left side, the transradiancy of the lung field, lower lung field has increased. So the field appears loosened, more of a loosened. But the vascular markings are seen there. What we are not able to, what is missing here is the breast shadow. The patient had gone through mastectomy earlier, and these are the pins. That's like a surgical staples. Okay, so it's a one added evidence for that. And this transradiancy is due to the removal of left breast. We'll go through the next slide. This is CT scan image. The upper one is axial cut. It's a contrast image, first one. And second one also, the lower one is also contrast enhanced image. But then lower one is reformation in a coronal plane. Upper one is axial plane. What we are seeing here is the right side chest wall. There is a large heterogeneous mass we get to see. And this mass is heterogeneously enhancing. It is invading ribs, then it's a pleura, right lung also it is invading. It has displaced the ribs, in between rib space also has increased here in the lower image. So this is a large mass. And actually the history of the patient was 2 years ago. Patient had gone through mastectomy for CA breast and had taken radiation. So now on the chest wall, we are seeing the large invading mass. On histopath, it has turned out to be fibrosarcoma, probably secondary to radiation. So we have seen another one chest wall mass. Next image, these are MRI images. These are MR images, and we get to see the left apical upper lobe, apical segment. We are seeing one soft tissue mass, large soft tissue mass. The mass is invading the adjacent soft tissue, including pleura. Then these are nerves roots, actually brachial plexus, and this mass. So it is starting from lung apex and invading the adjacent soft tissue. It is invading rib also. Here the mass is in here. It is close to the vessels around there, as well as nerve roots, pleura, and the ribs also there. It is close to. This is Pancoast tumor. It's a Pancoast tumor. So it is lung tumor, but invading adjacent soft tissue, pleura, ribs, vessels, as well as brachial plexus. So this is Pancoast tumor. MRI helps in seeing nerve roots very, very well on radiograph or on CT scan images, we don't get to see brachial plexus so well. So MRI is very helpful in understanding the status of the disease. This is another image. These are the CT scan reformations. First one is contrast CT scan, coronal reformation. Second image is contrast CT scan, parasagittal reformation. What we are getting to see here, this is the mass. This is again example of pancreas tumor. What we are seeing is it is almost invading left subclavian vein, artery, and left subclavian artery invading. So the lucency is there, partial, as well as the thickness has decreased. The contrast, amount of contrast has decreased because of stricture kind of a thing here, because of invasion. So it is seen, the less contrast is seen in this particular region in subclavian artery. Next image is showing erosion of the rib. Next image is showing erosion of the rib. Actually, the tumor is encasing the rib, and at the one side, that's the lower margin of the first rib. What we are getting to see is erosion. So this bony defect is bony erosion secondary to tumor. That was again example of pancreas tumor. You see next image here. Here we are seeing a dense rib. This is the left side of X-ray. It's a frontal view, chest X-ray. In that one particular view, rib is seen dense. This is first second. Ninth rib is appearing, left ninth rib is appearing denser, which is showing diffuse sclerotic changes, and it is relatively enlarged. We can see the upper rib and lower rib. Related to that, it is showing some expansion. That's enlargement as well as diffuse sclerotic changes. So what we get to see here is a single ribbage involved. This is the case of fibrous dysplasia, where the rib is showing expansion and increased density. This is ultrasound image. What we are seeing here is ultrasound image. This is liver and diaphragm. Above part is pleural space. So here is a large pleural effusion is seen with multiple septations, and largely anechoic areas are seen. These are few areas where the echoes are reflected back, as few echoes are seen. So this is secondary to turbidity. So this is the case of empyema on ultrasound we are seeing. So this is again, we are not talking about lungs. Here we are talking again about pleural space. So this is the first image. We're talking about pleura, pleural spaces. Earlier we saw chest wall lesions and all. Now this is, as I said, large pleural effusion, multiple septation, and some echogenicity within. It is empyema. And this is contrast enhanced CT scan image, axial image. What we are seeing here is large pleural effusion on right side. The important thing to be noted here is the pleura. This is visceral pleura, parietal pleura. So both the pleuras are showing irregular enhancement, irregular thickening, as well as enhancement. So this goes in favor of malignancy. Here is another lesion. So what we are seeing is pleural thickening irregularity and all. and then effusion is there. Other than this, there is one important finding. This is a case of CA breast. We are seeing soft tissue heterogeneously enhancing lobulated lesion with perilesional spikes and irregularity. This is CA breast lesion. This CA breast is giving metastatic extension to the pleura. So in this pleura, what we are seeing is metastatic foci. So this is a case of primary CA breast with pleural mets. Next image we are seeing here, it's very clear on the frontal view of radiograph, chest radiograph. What we are seeing is the right side, there is encapsulated large effusion is seen along the lateral wall, right lateral wall. And here, this area is a consolidation. Lower zone, there is a consolidation encapsulated large effusion, which is extending to the right costophrenic region. On the left side, on the same chest radiograph, what we are seeing is here also there is a effusion, but it is not encapsulated or encysted. This is showing horizontal line. And this is bilateral pleural effusion. Now we'll go to CT scan image, which is a very important image. Here we can see the difference. Large pleural effusion and moderate pleural effusion we are seeing on the large pleural effusion we are seeing on the right side. Moderate pleural effusion we are seeing on the left side. What is a remarkable thing is here is that pleura on the right side, this is a contrast CT scan image. Pleura on the right side appears thick and it is showing enhancement. Whereas on the left side, pleura is thin, regular, without enhancement addition. So what does it indicate is this pleura, this could be secondary to empyema. This is infected area on the right side. On the left side, without any infection, just a effusion it is. So one more finding is here, which I would like to add now. We can see here the parietal pleura and ribs in between that, the space has increased because of edema and inflammation. And the fat is getting involved and it is showing an increase in the space. So subpleural fat is showing infiltration by inflammatory process, and because of that edema is occurring of the fat, so that this subpleural space is increased. As well as this is complicated pleural effusion, and this is non-complicated effusion is seen on the left side. These are the images now, very important images. Now here we can see this is in deep inspiration and this is in deep expiration. So what we are seeing here, both the lung fields, one very important finding is on the left costophrenic angle region, we are seeing some amount of effusion, pleural effusion. Left costophrenic angle blunting is seen and effusion is seen. In addition of, there is one very important finding here. Here we are seeing area, lucent area relative to lung. This area is more lucent, and the vascular markings, bronchoscular markings, and vascular markings are not seen void of any markings. More translucent, and just medial to that, there is a linear appreciable line is there, thin line is there. So that is limiting the lung, and this is the case of pneumothorax on the left side. Okay, what I wanted to show here, important thing is the deep expiration, the lungs are more, the left lung is pushed to the medial side, as well as pneumothorax has become more apparent. The lung volume has gone down the left, so it is helping in making it more denser relative to this transradiancy, as well as the image is very clear on the deep expiration. As we have noted earlier, effusion is seen in the both images. What is here important point to be noted is pneumothorax is seen better in the deep expiration film. We'll see the next image. This is a supine film. We can see here, there's a bedside radiograph actually, and we are seeing endotracheal tube, mesogastric tube, ECG leads and all. This is portable bedside radiograph, and the patient is supine. So in the supine radiograph, what are the features of pneumothorax? Because pneumothorax usually we see in erect position, and if there is a effusion, we get to see hydropneumothorax, and that becomes obvious, easy to pick up. But in supine case also, it can be picked up. Moreover, the sick patient, admitted patient, ICU patients and all, which the picking up of pneumothorax becomes more important, and it's crucial so that it is kept this image. What we are seeing here is the transradiancy has increased in the left lung base region, and the costophrenic sulcus laterally, the radiant thing, transradiant thing is seen. It's more darker area is seen. So this is due to pneumothorax. Now we are seeing other conditions of pleura. We have seen effusion, then empyema, then pneumothorax, then hydropneumothorax. Now we are seeing other condition of pleura. Here we get to see opacity, fairly defined elongated opacity starting from the lower thorax and covering mid-lower thorax. So this is a pleural plaque. So pleural plaques are common in lower thorax and along the diaphragm. So this on X-ray, what we are getting to see on this particular radiograph is here the large plaque is seen here. Okay, you see, CT scan images are here. First one is upper one is axial, and the lower one there is in a coronal plane. Very important finding here. What we are getting to see is these are the ribs actually. Along the pleura, there is thickening is seen, as well as the density has increased. So some amount of calcification is there, thickened, and some proper calcification, soft calcification, as well as dense calcification foci are also seen. So these are thick plaques along the posterior pleura. On coronal images, we are seeing here on left hemidiaphragm, the pleura along the diaphragm is showing dense, thick plaque. On the right side, it is more elongated and more plaques are seen. So these calcific plaques are there seen on the along the chest wall as well as along the diaphragms. So this was the case of asbestos exposure. As we know, asbestos exposure in long duration can give the pleural plugs. Next image. Here also again we are seeing irregular and thick pleura. First image is axial image in contrast. It is a contrast study. What we are getting to see here is thick, irregular, very thick, irregular wall, irregular margined, thick pleura we are getting to see here. Few nodes are also seen, mediastinal and hilar region nodes are also seen. Few lymphadenopathy is there. On this coronal image, other important findings are also seen. The mediastinal pleura also is shown thickening, diaphragmatic along the diaphragm also the pleura there also nodular thickening is seen, as well as a very important thing along the fissure there are nodular soft tissue opacities are seen. This is the fissure line actually, and along that there are nodular soft tissue opacities are seen. So these are fissure and pleura related soft tissue thickenings are there. So this is a case of malignant mesothelioma, which is involving pleura along the thoracic wall, along the diaphragm, as well as along the mediastinum. In addition of that, fissure is seen getting involved, as well as mediastinal and hilar lymphadenopathy is also seen. So this is a case of malignant mesothelioma. We'll go to the next image. Here, what we are getting to see is large soft tissue mass based on chest wall. Another mass is here seen along the apical pleura as well as mediastinal pleura. Along the right hemidiaphragmatic pleura, there is a large mass which is showing almost invasion into the diaphragm, as well as maybe it is extending up to the liver. So these lesions, soft tissue lesions, which are showing heterogeneous enhancement, and they are on the pleura basically. So these lesions are metastatic lesions. These are metastatic lesions. Here we are seeing large, uniform, very sharply marginated, non-regular marginated, very clearly marginated soft tissue mass based on left chest wall. And this mass is showing obtuse angle to the chest wall. This is indicative of chest wall based mass with a obtuse angle. This is indicative of it is not originating from lung, it is maybe originating from chest wall. This is a large soft tissue mass, very well demarcated mass. It's a homogeneous mass. So actually this angle and the way the mass is based on chest wall, it shows extrapulmonary origin. This is very important point on this. First one was frontal view, chest radiograph. This is lateral view. So this is a case of benign pleural fibroma. See, here again, irregular thickening of pleura is seen. This is enhancing irregular walled pleura. This is a case of malignant mesothelioma. Here, what we are seeing are this is first is contrast enhanced CT scan image. B image is PET image. B and C. This is axial image and this is coronal image. The uptake is seen. What is used here is 18F fluorodeoxyglucose isotope, and that is showing activity along the pleura. This is fusion image. CT scan and PET image is fused. So that is showing clearly showing the uptake activity here, the radioactive material. So this was malignant mesothelioma. We'll see next image. What we are seeing here again is a thickened pleura. Additional finding is there is a node here, lymph node. There is a muscle pectoralis, subpectoral region, there is a node, lymph node. On this contrast study, the heterogeneous enhancement of pleura is seen. Node is also showing some kind of enhancement. Next image is sonography image of the pectoral region. Here, important thing is this is the node, which is apparently hypoechoic. Through that node, there is a biopsy needle seen here. The arrow is marking to the biopsy needle. So this was the attempt to take out two-cut biopsy for the evaluation of the node, and the images are according to that. We'll see the next image. Here again, it's a fusion PET image is showing uptake. The same uptake along this irregularly thick pleural nodule. So the next image is showing needle is here for biopsy, two-cut biopsy. The CT scan image, same nodule, same mass. The attempt of taking biopsy, two-cut biopsy is here. Now we have seen the chest wall, then pleura. Now we'll start our third part of this topic. That's a diaphragm. What we get to see here, there are four images. One is frontal chest radiograph, lateral chest radiograph, coronal contrast enhanced CT scan. These three images are very important. So let's look at this. There is a on this X-ray, on this radiograph, we are seeing hump, the diaphragm. So elevation is there. Okay. This is a focal area of elevation. Here also we are seeing focal area of elevation. So here on the coronal reformatted CT scan images, we get to see diaphragm is thin, even, and regular. What we are seeing is liver is as a content below it, without any diaphragmatic pathology of mass or any focal pathology. This is a focal eventration of diaphragm is seen. Focal eventration of diaphragm. Next image, lateral view of chest radiograph and deformated parasagittal CT scan. It's a very interesting case here. What we are having the finding here is well-defined soft tissue lesion is seen based on hemidiaphragm. A diaphragm on the posterior side. Just posterior to that is posterior recess of the lung. This is the lesion. It is based on diaphragm. On CT scan deformation, two important findings are seen here. There is a discontinuity, incontinuity of diaphragm, focal incontinuity here, and fat has gone, mesenteric fat or peritoneal fat has gone through it. It is herniated. This is herniation. Diaphragmatic hernia it is. On the left side it is, and it is posteriorly. So this is a Bogdelic hernia, which is in the form of bulge it is seen along the diaphragm, as well as incontinuity of diaphragm is seen. So this is Bogdelic hernia. We'll go through another images. What we are getting to see on frontal radiograph, it's like a left part is shown here. This is a case actually. First trauma, after trauma, post-traumatic X-ray immediately after post-trauma, we are getting to see multiple rib fractures. Then hemothorax, pleural space is occupied by blood, as well as there are lung contusions, rib fractures, lung contusions. It was the status. Then after a month or so, this radiograph is taken. Actually, other than rib fractures, the large hemothorax is almost resolved. Minimal blunting of left CP angle is seen, but otherwise largely it is actually resolved. After a month of it, with some activity by the patient, the diaphragm must have got injured in the first thing. So it has given up, and rupture of the diaphragm has happened. What is seen here on the images is this air here. So this was a stomach herniated through ruptured diaphragm, and left hemithorax is this is part of normal lung, and left hemithorax is occupied by herniated content of peritoneum. Another finding is mediastinum shifted to the contralateral side, right side. Right lung is actually normal. So this was a typical case of rupture of diaphragm. Here we are seeing cross-sectional CT scan, which confirms the diagnosis. We are getting to see stomach in the thorax through the ruptured left hemidiaphragm. S indicates stomach, and on the supine image, this we are seeing air fluid level in the stomach. Here another additional finding is fusion is seen here. So this was a rupture of diaphragm with stomach herniation on the left side. Now another diaphragmatic rupture case we are seeing, but this is on the right side. So right lung base region or right lower zone, right mid zone area is hemithorax, lower hemithorax, right hemithorax is obliterated lung shadow, and dense haziness is there. On reformated coronal reformation of CT scan, what we are getting to see is collapsed lung here. This is the lung area. Lung base is collapsed or right lung's lower lobe is collapsed. And what we are seeing is there is herniation of liver. So here another finding is here. Here we are getting to see some lucency or some indentation on this side. This was the edges of torn diaphragm, which is still restricting liver to go up. So because of that, this notch has come on the liver at this region. So this is again ruptured right dome of diaphragm with liver herniation, intrathoracic liver herniation. This is the last slide, and what we are seeing in this image is irregularity of diaphragm, blunting of right costogenic angle. These are the findings. On the CT scan, what we get to see here is large soft tissue mass, which is showing heterogeneous enhancement as well as central necrosis. The lesion is invading, it is indenting into lung as well as it is invading the lung liver. So this is an aggressive lesion which is invading liver, and this turned out to be primary malignant tumor of diaphragm. So it's a diaphragmatic malignancy. So the same thing is seen here on this image, where we get to see invasion into the liver of the neoplastic mass. So with this image, we have done with our topic of lesions of chest wall, pleura, and diaphragm. Thank you very much.